pleasure of introducing Dr. Alan Hampson, who for the last 40 years or more has had a career within virology. Today we're going to really focus with influenza and the workplace, because we find that there seems to be a little bit of a miscomprehension about what to do, how to manage a workforce with influenza, how to deliver education, and some of the really nitty-gritty science behind it. So without further ado, I'll hand over to Alan.
Well, good afternoon, and thank you, Sue. What I'm going to do is to cover a number of areas of influenza and talk about what the disease is, the illness itself, the viruses that cause it, the impact of the disease, how we can deal with it, particularly with reference to the workplace, and quite a bit about vaccines and vaccination. So there's background here that's, I guess, some of the science that relates to influenza. I'll make it simple, but I think it's important for people to be able to really appreciate more about this illness. So what is influenza? And clinically, it's fairly typical when you get full-blown influenza. It's a fever with chills, myalgia, muscle aches and pains, headache and cough. And these are things we call influenza-like symptoms or influenza-like illness. We contrast that with the common cold, which is more often runny nose, rhinitis. You often get sinusitis, but you very seldom get a temperature or myalgia, the systemic symptoms. But there is an overlap, unfortunately, and that makes it sometimes a little hard to be sure exactly what we're dealing with. And flu symptoms can actually range from essentially nothing, very little, maybe just a bit like a cold, right through to typical symptoms and even through to pneumonia. Other virus infections, on the other hand, can masquerade as influenza-like on occasions. On average, we believe that about 15% of the population suffer influenza annually, and about 30% of infants and young children whose immune systems have not been exposed previously. The acute symptoms usually last for about 3 to 5 days, but the cough that you get with influenza can certainly persist for a long time, weeks or even months on occasions. And typical workplace studies that look at the impact of influenza look for absences of 3 days or more as being typical absences due to influenza. We have to remember that adults suffer maybe 2 to 3 colds a year, more frequently if you've got young children, because children suffer lots of colds, 6 to 10 a year, and they spread it fairly liberally. So people often say they've had a touch of the flu, and it may just be that, but more likely it is a common cold on most occasions. When we talk about epidemiology, we mean what happens with the disease. And with influenza, we have repeated infections throughout life. That's unusual. We don't normally get repeated infections of any disease. It's seasonal in temperate climates, but year-round in the tropical areas. And I've just put up a little graph here that shows the winter season in red for the southern hemisphere and in blue for the northern hemisphere, and showing that you tend to get flu year-round in the tropical areas. That's important for people who are travelling overseas to know that influenza can be there at any time when you're going through tropical areas. And we say that it has a rapid or explosive spread quite often. If you get it into a particular environment, nursing homes, places like that, it will go through a population within a very short period of time and infect a high percentage of people. And we do have outbreaks every year. We have fairly frequent epidemics, and we have occasionally what we call pandemics, worldwide epidemics that sweep around the globe, totally new influenza virus that's come out of nowhere quite often and infects many, many people. Now, when we talk about influenzas, there are 3 families of influenza viruses: influenza A, B, and C. Influenza C tends to be rather unimportant. It's a mild disease. It's a bit like a common cold, usually infects children. Influenza B causes outbreaks and occasional epidemics, and influenza A is generally the more severe form outbreaks, epidemics, and these worldwide pandemics on rare occasions, maybe about 3 a century. And when we look at the virus under the electron microscope, here is a picture of it magnified many millions of times. We see these little baggy structures with a hairy surface on them. And if we represent that schematically, it looks a little bit like this. This is rather simplified, but it has 2 proteins on the surface known as the hemagglutinin and neuraminidase. That's just important in terms of nomenclature. They are the H and the N that we often hear described as an H3N2 virus or an H3N1 virus. And I've shown here that the genetic material in the virus is RNA. It's in separate pieces, and it's all bound up in a lipid envelope. And these are important when we come to consider the properties of the virus. Influenza A has lots of different subtypes based on these different H's and N's. They've actually evolved in birds, but they can become established in humans and other species. Influenza B is just one big family of viruses. When we look at the naming of influenza viruses, the naming is based on the type of virus, whether it's an A or B, the place of the specimen that yielded this virus, such as in Perth, the sequential lab number in the laboratory there in Perth for the year, and the year. And sometimes we put that subtype after it. So a Perth 19-2009 virus is a typical type of virus that comes up in our nomenclature. Having a little bit of a look at the influenza viruses, influenza is the infection with viruses of a group that's known as the orthomyxoviruses. Now that won't mean much to you. But it's important to know is what a virus really is. And unlike other life forms, including bacteria, a virus is a little package of genetic material. It's not a living thing as such, and it can only replicate itself or multiply once it gets inside a living cell. It then directs your cell as a factory for more virus, in effect. And it's usually specific for a particular type of animal species, distemper, for example, in dogs, and for a particular organ. And influenza tends to be a respiratory infection. But I've just put up a little picture here of all sorts of different viruses, just showing how diverse they are. They're enormously diverse. And what I often say to people is, from one virus to another, the genetic difference and the shape and size is more dramatically different than the difference between a mouse and an elephant. Immunity to influenza, well, we do have some natural resistance. By being healthy, it doesn't really protect you against an infection, but by being unhealthy, it certainly makes you more susceptible. So people with malnutrition, for example, are more susceptible to infections. People who smoke are more susceptible to infections. And I've just shown little pictures of those cilia, the little beating hair-like structures on your respiratory tract that keep it nice and clean. What happens in smokers, they're stunted, they don't function properly, and so you get things laid down in the respiratory tract, not swept away, so the greater chance of infection. But most of our immunity is acquired specific immunity. It's antibodies that are derived from infection or vaccination in the case of influenza. And what I'm trying to show here with this model, let's pretend the virus has got key-like structures on the surface. These are the surface proteins. And we make antibodies that fit against these keys and bind against them and stop the virus from actually infecting cells. Now, when the virus mutates, it changes those key-like structures, and when the antibodies come along, they can't grip properly to those surface structures, and so they become less effective or ineffective at protecting us. So this is why we have to keep updating our vaccines to accommodate that. How is influenza transmitted? Well, this is how it's transmitted. If you backlift somebody in an elevator and they cough, this is what you'd see, all these nasty little droplets coming out from their mouth as they cough or even as they sneeze. And inside them, they may well be carrying influenza viruses. And there are 3 methods by which we can contract influenza. The little particles that stay in the air for a while, travel a few meters, breathe them in, it infects your respiratory tract. Bigger droplets, they travel a shorter distance and they stay in the air for a much shorter period of time, and they can get deposited on surfaces. And you can deposit material, viral-containing material on surfaces by your hands, by blowing your nose, coughing into your hand, and then touching something. Typical things around an office: keyboards, telephones, photocopiers, door handles. These are all ways that you can become infected, and the virus can live on those surfaces for quite some time. If we look at transmission of influenza, from the time that you're infected, as shown by the red star here, you very shortly after that start to produce virus in your respiratory tract and to shed it from your respiratory tract. So from a very early stage you're shedding virus, but you really don't develop symptoms such as the fever, the aches and pains, the things that are going to actually make you go home and go to bed if you're wise. So there's this period of about a day where people can be shedding influenza virus before they really develop symptoms and are aware that they are in fact ill. Impact of influenza, something that we tend to very much underestimate. William Farr, who worked in the British Records Office back in the 1800s, described what we now know as excess mortality associated with influenza. We also see excess hospitalisation, which runs pretty much parallel to this. So what is excess mortality? Well, Farr was looking at death certificates and the causes of death shown on death certificates around that time. And there was this background of things that were going on: whooping cough, consumption, TB, measles, diphtheria, etc. He found when he got an epidemic of typhoid, there was suddenly a big spike of typhoid marked death certificates. Nothing else changed. And the same thing happened with cholera. But when there was an epidemic of influenza, lo and behold, there were a lot of death certificates that said influenza, but there were a lot more death certificates that said other things such as heart disease, pneumonia, diabetes, stroke, kidney failure. And these are things that are precipitated, deaths that have been precipitated by infection with influenza, and it's gone on many occasions unrecognised that influenza was the thing that precipitated this. And we have data from Australia and New Zealand and the USA all indicating that this excess is about 10 times the number of deaths that are actually recorded with influenza on the death certificate. So we grossly underestimate this disease if we're not very careful. In America, they do a very nice job of actually tracking influenza each year, and they look at influenza and pneumonia mortality, and they've got a curve here which I've shown, which is the anticipated if there's nothing unusual happening, and then in years where there's a major outbreak, a big epidemic, the red line shows that it exceeds this quite dramatically on certain occasions. And most of those deaths are occurring in older people. Once you get over the age of 65, you're more likely to die if you contract influenza, but then once you get over the age of about 80, you're much more likely to die. And just showing a little blip at the beginning of this curve, because very young infants are also susceptible, potentially could die from influenza. But it's not only the known at-risk people, the older people, or people with underlying risk conditions that are totally susceptible to mortality from influenza. I collected for a period of time newspaper cuttings of unexpected deaths in young, otherwise healthy people, and these build up and make quite a dramatic story that young people can in fact die unexpectedly from influenza when they've had no other underlying causes. And in the 2009 pandemic, this H1N1 pandemic in Australia, approximately a third of the 191 deaths and of the large number of ICU admissions, intensive care admissions, were in young adults with no unidentified risk factors. And most commonly there was lung involvement. The virus actually invaded the lungs in those people. And we just have a look here at a graph showing where the deaths occurred over a number of years in Australia, going back to 2000 and up to 2009, the pandemic year. And what you see is generally in older people, as I said earlier. In 2009, it was a relatively mild year in terms of numbers of deaths, surprisingly, because there was so much influenza around. But it did attack younger people. And if we measure the impact of influenza in terms of the number of years of productive life lost, this was quite dramatically different in 2009 to most other years. Now, influenza causes illness, serious illness and death in several ways. It can invade the lower respiratory tract. It's normally an upper respiratory tract infection, but occasionally it gets right down into the lungs and causes pneumonia or pneumonitis, and that certainly happened in 2009. And a lot of people were kept alive. We're very fortunate to be able to survive that by these extracorporeal membrane oxygenation systems, artificial lungs, if you like. And a lot of people were wired up like this picture for days or even weeks while their lungs recovered enough for them to be able to breathe again. Also, the virus does predispose to bacterial infection. I talked about the little cilia that keep your respiratory tract clean. On the left here is a typical respiratory tract before it's been infected, and to the right after influenza infection. And influenza wipes out these little cells on the surface with these cleaning cilia on them, and it predisposes to bacterial infections, so you get bacterial pneumonias can take over. And also, as we get older, our physiology becomes compromised. I've just shown on here lung capacity as one of the things that you can measure. Heart capacity, kidney capacity, all of those things become more compromised with aging. And if you have a severe infection, that can actually cause organ failure. You can actually die simply because you're not physiologically as strong as you used to be, and this is why older people do succumb to influenza. And pregnant women also succumb because of their compromised immune systems and because of their compromised respiratory tract. And there are a whole lot of strange things happen when our body responds to influenza. The body produces a whole lot of compounds which are supposed to fight the viral infection. They're things we call lymphokines or cytokines, but they're the things that actually make you feel ill. They give you the fever, they give you the muscular aches and pains, but they can do other nasty things on occasions, such as dislodging plaque from your carotid arteries, and that plaque can go to the brain or to the lungs or to the heart and can cause thrombosis, can cause myocardial infarction, heart attack, or can cause a stroke. So influenza can do some really nasty things. And on rare occasions, it can also infect the heart or brain tissues and cause its affecting that way. What's the impact of influenza? Well, WHO feel that somewhere between 3 and 5 million cases of serious illness occur a year. Somewhere between 250,000 million deaths occur. Pandemics are terrible outbreaks, and I won't dwell on those because they're a very special case. In Australia, we've done some work which shows that between 1,500 and maybe 2,500 deaths occur a year, a lot of it by this excess mortality. Probably something like 18,000 people hospitalised and about 300,000 GP visits, excess GP visits on an average. And the cost of the healthcare system is something like $85 million. We've got an old estimate that suggests that about 1.5 million days of work are lost a year. But based on some more recent work in 2007 from the US, where they recorded 44 million work days lost, it's likely to be double that. So we're probably looking at over 3 million absentee work days a year in Australia. And about 10 to 12% of work absences are thought to be due to influenza during a year, and each of those on average is probably going to be about 4.8 days. Again, I won't dwell on pandemics, but I'll move straight on to our own recent survey that we did through the ISG, looking at what we call presenteeism. And what we found was in a wide-ranging questionnaire, about 90% of Australians have gone to work when they're suffering typical influenza symptoms. And there are a whole variety of reasons. They didn't think it was necessarily serious enough. They don't want to let their colleagues down. They don't want work building up and missing deadlines. But one of the nasty and surprising things is a very recent survey done in the US showed very much the same sort of things was happening with hospital interns, residents, doctors. And a good percentage of those felt responsibility care for their patients, which is a little incongruous because an ill doctor with influenza dealing with people who are already seriously ill is likely to actually pass the infection on and kill their patient. Almost 70% of Australians also participated in social activities, but on the other hand, most of them, about 61%, believe that a person with flu symptoms should actually stay at home. So it's more a matter of do as I say, not as I do. What are the costs of presenteeism in the workforce? There have been a number of recent estimates of that. In the US, they show about double the cost of absenteeism. A Medibank survey done in Australia in 2000 actually assessed it as something around 4 times the cost of absenteeism. And the effects of influenza are rather unusual or surprising in some ways because mild episodes of influenza or other respiratory illnesses can actually impair people's reaction times. By comparison, consumption of alcohol probably produces a lesser reduction in one of the major studies that was done back in 1998. And we see repeatedly in the literature these sort of estimates. This is a news article based on an insurance company which said that driving with a cold or the flu is equivalent to the effect of driving with a double whiskey under the belt. So it's probably quite important to your workplace. The potential for loss due to people being present can be even greater than being absent. What can we do about influenza in the workplace? Well, we can certainly encourage absenteeism rather than presenteeism. Now, that may be a little hard to do, but economically it may be much wiser than trying to encourage people to come to work. We do tend to have people encouraged to come to work with the flu and with serious colds by a lot of the advertising that we see on television these days. Take these cold and flu medications and soldier on. These are analgesics. They make you feel better. They don't reduce the infection, and they do encourage you to do the wrong things, unsafe behavior, working, exercising, socializing, and spreading infection and stressing your body. There are prescription antivirals available. They're fairly expensive, must be taken within the first 2 days of onset of infection, but they can certainly reduce the period of infection and the severity of the infection. They don't make you instantly feel better, so maybe you do have to take them with the cold and flu medications. You can encourage good workplace hygiene, reminder signs, covering your cough, disposing of tissues, and you can encourage people to wash their hands and use hand gels to stop them contaminating the surfaces that they're touching and spreading the infection to other people. Or you can vaccinate your workforce. So who should be vaccinated? Well, based on the Australian Immunisation Handbook, the 9th edition in 2008, the 10th edition is about to be published and it will be much the same. And they start off by saying anybody wishing to reduce their risk of becoming ill with influenza. So in effect, that's I guess all people in the population who really don't want to be ill with flu during the year. But there are a whole lot of people who are at increased risk of severe complications, and those are listed here: older adults, people with underlying risk conditions, pregnant women, people in institutional environments. And people who may transmit influenza to high-risk individuals. If you're a carer for somebody who's looking after a high-risk person, or if you're in contact with somebody who's pregnant, for example, a good idea for people to be vaccinated. That bracket in the middle are entitled to free vaccines from the Australian government. Older Australians tend to avail themselves of that. A lot of the people with underlying risk conditions unfortunately don't, and we're not really sure why. They don't necessarily recognise it, or they don't get around to going to the doctor to have their flu shot. Now, there are a lot of questions I hear very frequently about influenza vaccines. How they're made and what's in them, why do we have to have them every year, do they cover all the strains, aren't there hundreds of viruses out there that you couldn't possibly protect against, are they safe, are they likely to cause influenza or other things, and are they effective, will they really keep you healthy during the winter? Well, they're made by growing virus in embryonated chicken eggs. Currently all Australian vaccines, all the vaccines available in Australia are made in this way. It's very old technology, but it has been improved dramatically in terms of the cleanliness and the processing of the product that comes out of that. And hopefully we will move to producing vaccines under other conditions in fermenters in cell culture in the future. The virus, having been grown in the eggs, is concentrated, purified and activated using very, very sophisticated centrifuge technology. And then this virus, after being inactivated, is actually split, we call it. It's broken apart into little pieces. So there's the virus being broken. And on occasions, some companies actually take their vaccine a stage further and purify just those little bits of H and N on the surface, which are the pieces that the body responds to in producing immunity. They're essentially the same. There's no discernible difference in terms of the reactions to the vaccine between a split vaccine and a purified subunit vaccine as shown here. And what I didn't say there was that they're standardized, formulated, put into individual syringes and administered either by intramuscular or subcutaneous injection, that's into your arm, or one vaccine has a little tiny needle which is, goes just into the skin or just under the skin. So what's in the vaccines? Well, essentially it's just bits of purified viruses, salts, sodium chloride, phosphates and the like that are there to suspend the virus, purified water, and some very small traces of detergents, non-toxic detergents, and maybe a trace of egg proteins. Why are we splitting the influenza vaccines? Well, it was found some years ago that even if you purified influenza virus to a very high level and inactivated it, it still tended to cause some flu-like symptoms on occasions, particularly in young children. And this is a study that was done many years ago showing if you take the temperature of people before you give them a dose of influenza vaccine, a whole influenza vaccine, and then measure it 24 hours later, almost everybody has got an elevation of temperature to some extent. If you actually break the virus up into little pieces, that goes away. So you get a much less reactive vaccine. In fact, it does make the current influenza vaccines very, very safe and very non-reactive. When we look at the production time for influenza vaccines, of course there's this lead time of getting the chooks to produce the eggs, but people anticipate that. So it really all starts from the time that the vaccine formulation decision is made, and that gives you a period of about 20 weeks before the vaccine is coming out the door. Now, that unfortunately is a period that at the moment with our current production we can't avoid. So there's a little bit of a delay compared with the surveillance that goes on. Why are the vaccines produced annually? Well, as I said earlier, these viruses are mutating all the time. A lot of effort's being put into longer-lasting vaccines that might attack other parts of the virus that don't change, and they may be getting a little closer at this stage. On the other hand, our antibody response to the inactivated flu vaccines does decline fairly quickly. It might be adequate beyond 12 months in healthy younger people if the strains don't change, but that's fairly rare. And the more antibody that we have, the more response that we have, the better our protection. Do they cover all the strains? Well, we've got this worldwide network of laboratories through the World Health Organization, surveillance looking at the 3 families of influenza virus that are circulating in the population and tracking the changes that go on in those viruses, the type A's, the 2 type A's, and the type B. And this is a program started in 1947 that's grown to now include 140 national centres, 5 major centres in the world, one of which is here in Melbourne. They're all collecting and analysing viruses. And the vaccine formulation is reviewed and updated, if necessary, twice a year, once for the Northern Hemisphere and once for the Southern Hemisphere. And we decide on which strains to put in the vaccine by looking at how they react with antibodies that have been produced in experimental animals, but now also looking at the genetic changes that are going on in the virus. And we can make these maps. There's an antigenic map, which is the map of the antibody binding of the virus on the left-hand side. It doesn't necessarily go along a straight line, and a genetic map. So by tracking it in 2 different ways, and also by looking at the antibody responses that people have made to last year's vaccine and comparing that with the most recently isolated virus strains, we can decide which viruses should be going into our vaccine to give us the best cover for the new season's viruses that are coming up. Are they safe? Well, the current vaccines certainly cause some injection site reactions, a bit of soreness, a bit of redness, and occasionally they give you some short-term systemic reactions, a little bit of fever, a little bit of headache. We haven't totally got rid of those. Some people are more susceptible than others. Here is what we call a crossover placebo study, where half the people were given vaccine, half of them were given a harmless, just neutral salt solution, and then you come back a month later and give them the opposite of what they had originally, so that you get rid of any bias from the individuals, and you monitor the reactions that they had. And when we have a look at all the local reactions, 17.5% of people with vaccine, 7.3% of people with placebo. That is a significant difference, and it's mainly just soreness to touch, really. That's the difference. If we look at what we call systemic reactions, any indication of fever, headache, or feeling off colour, the difference is very, very small and actually doesn't make significant levels. So this is a good indication that the vaccines are, in fact, very safe and non-reactive. Can you get flu from the vaccine? Absolutely not. People say they've had flu from the vaccine. They can't possibly get flu from the vaccine because the virus has been killed and it's been broken into little pieces. But what about more serious reactions? There are the potential for anaphylactic reactions, hyperallergic reactions, for example. There's been a concern about a condition known as Guillain-Barré syndrome, heart attacks, neurological problems. All of those things people have said could occur as a result of influenza vaccine. And if you have a look at a very large database in America and have a look at the reports, now I've highlighted here, this is reports where people, doctors, report any suspected adverse event to a vaccine or to medications as a whole, goes into a large database, and then they're evaluated. And what this one shows is that about 3 reports of potentially serious reactions occurring per million vaccinations. When you look hard at those, it's essentially impossible to show that they are associated with the vaccine. These are things that are going along in the background in the population anyway. And as I've often said to people, within a period of time, maybe 2 weeks or whatever, having a flu vaccine, I'm sure there are about 3 or 4 people in Australia who've fallen over and broken a leg, but we can't blame that on the vaccine. And these other things really don't relate to the vaccine. There was a case where Guillain-Barré syndrome, 1 year in America in a big study or in a big vaccination program, did appear to be at a higher incidence than in an unvaccinated population. That's been studied in great detail ever since, and maybe about 0.7 people per million vaccinated just might suffer Guillain-Barré as a result of the vaccination. What recent studies have shown in France and other places is, in fact, you've got a much greater chance of contracting Guillain-Barré by contracting influenza. And so the vaccine does, in fact, appear to be protective against Guillain-Barré syndrome rather than causing an excess of Guillain-Barré syndrome. And the same thing goes for heart attacks. By preventing people from becoming infected with influenza, you prevent them from actually having a myocardial infarction. So the vaccine is probably protective against most of these things. How effective are they? Well, the answer really depends on what you look at, how it's assessed, the population you're assessing it in, whether you're looking at illness, hospitalisation, death or anything else. And I've just put up a few figures here of the more firm data that we have from good trials showing close on 90% protection in children, between 70 and 90% complete protection in healthy adults, and even in high-risk people where the reaction, the responses are less, certainly very high levels of protection. And this is the best we can do. There's a single trial in adults over the age of 65, shows about 58% protection against infection. If people do become infected, despite having the vaccine, the probability is that, in fact, they're going to have a less severe infection. What about workplace vaccination? Is it cost effective? Well, we have a look at the published literature, the medical literature, and a recent review through the National Institutes of Health in America concluded that a workplace vaccination program appears to be relatively inexpensive, potentially cost-saving for a wide variety of employers in diverse industries. And here is one study looking at, a very good study, looking at giving airline employees vaccine or a placebo. The P there is the placebo, the V is the vaccine, and then looking over a period of time at how many people became ill and were absent due to influenza. And there was quite a marked difference between the two. So this is clearly working in this particular case. And there have been few good studies of this nature for us to be absolutely certain about, but there have been lots of observational studies which certainly do indicate that there are cost savings to be made on many occasions by vaccinating. Here is a summary from an American journal of savings between $15 and $50 per employee, and the important factor of it providing a degree of employee satisfaction as well. What determines the cost effectiveness? Well, how much you pay for the vaccination, severity of the season, which can vary, as I said, the nature of your employees, their health and age, and that varies dramatically across industries, how many of them will actually avail themselves from a program, and whether they're likely to be exposed, whether your workplace situation is where employees are close together, whether they interact with the public, whether they're transiting to work on public transport, which is a really good place for spreading influenza, and other work-related travel overseas, not on aircraft so much, but in baggage halls and boarding lounges where people are crammed together a little bit like cattle and spread disease amongst themselves, and you're meeting people from all around the world. And the absence affects whether the employees are costed, whether it's costly to replace them, or whether you have opportunity costs. But we mustn't forget presenteeism, compromised performances, errors that cost, maybe just accounting errors, safety breaches, a crane driver, somebody working on an oil rig could cause terrible injuries by making a mistake because of them being ill with influenza.
Look, thank you very much, Alan. Let's keep in touch, and everybody, this is the last in the Lunch and Learn series for 2012, and I look forward to seeing you all next year. Thank you.